This is Cormac Gavin from London presenting our video lecture, which accompanies our chapter on the pathobiology of true AVMs by Cormac Gavin and Neil Kitchen in Humans and Wynn, Neurological Surgery, 8th edition. AVMs were described by Virchow in his landmark textbook in 1863. Virchow first described AVMs as angioma racemosum arteriale in his landmark textbook in 1863. It wasn't until the early 20th century that our modern concept of cerebrovascular malformations was defined by Cushing and Dandy, both publishing separately in 1928. In fact, it was Dandy who, referring to the earlier work by Virchow, noting the observation that these were not new growths in the usual sense, but were of congenital derivation. In 1966, McCormick defined 5 types of vascular malformations, including fistulas. In 1971, Dorothy Russell, working at the Royal London in collaboration with Lucien Rubinstein in Virginia in the United States, defined 4 types of vascular malformations, which are now accepted as the standard nomenclature. Cerebrovascular malformations are classified according to their histopathological features as arteriovenous malformation, venous angioma, cavernous malformation, and capillary telangiectasia. True brain arteriovenous malformations, also known as AV fistulous malformation, pial AV malformation, parenchymal AV malformation. True AVMs are abnormalities of the intracranial vessels in which the arterial and venous systems are connecting without an intervening capillary bed. There are 3 typical morphological features, which namely are feeding arteries, draining veins, and a dysplastic vascular nidus, which is composed of a tangle of abnormal vessels that acts as a shunt from the arterial to the venous system. The word nidus itself derives from the Latin for nest and was a term first described by Cushing and Bailey. The nidus is essentially a conglomeration of numerous AV shunts without interposed brain tissue and with no capillary bed. Microscopically, as we can see in the slide on the right-hand side, it consists of thin collagenous walls in the venous system, together with muscular elastic walls of the feeding arteries. AVMs are high-flow cerebrovascular lesions consisting of a tangle of abnormal blood vessels. The absence of a capillary bed results in low resistance, and with the AV connections permits high-flow arteriovenous shunting. Now, though the feeding vessels and draining veins themselves may not be congenitally abnormal, the communication of blood through the nidus subsequently leads to arterial dilatation and venous arterialization. Aneurysms are associated with AVMs in approximately 2.3 to 16.7% of cases. One theory of their formation is that they are secondary to a high-flow vasculopathy. Aneurysms are categorized as being either flow-related, as the majority, or flow-unrelated. Aneurysms also exist within the nidus, and these account for approximately 5.5% of flow-related aneurysms. Varices may also form as a result of the altered cerebral circulation, and these are associated with an increased hemorrhagic risk. Another feature of AVMs is the perinidal capillary network which surrounds the nidus, and if this is not completely excised at the time of surgery, there is a reported risk of recurrence. Parenchymal elements around the AVM are generally gliotic, hemosiderin stained, and non-functional. The figure on the right shows the typical appearances of an unruptured cortical brain AVM at the time of surgery. The next slide shows a classic AVM sequence which is taken from our chapter. Axial and coronal T2 weighted and sagittal T1 weighted MRI images show multiple vascular flow voids within a left frontal AV malformation extending from the cortex down to the frontal horn of the left lateral ventricle. In figure D, we see a left internal carotid injection, lateral projection during angiography, which shows that the arterial supply is via a left middle cerebral artery branches with early venous drainage. Using super-selective angiography, it's possible to define the nidus more clearly prior to therapeutic intervention. This slide, also from our chapter, demonstrates an AVM-associated flow aneurysm. Axial T2 weighted MRI imaging shows a left temporoparietal peel AV malformation with an associated left middle cerebral artery flow aneurysm indicated by the arrow. Digital subtraction angiography shows the nidus of the AVM supplied by the left middle cerebral artery branches. Interestingly, the left middle cerebral artery bifurcation aneurysm is seen less clearly than on the early angiographic runs. Brain AVMs are classified as being either sporadic or syndromic in origin. Sporadic AVMs being the most common, with a global prevalence of approximately 0.04 to 0.52%. It is estimated that the incidence of a newly diagnosed AVM is approximately 1 per 100,000 persons per year. Syndromic AVMs account for only 2% of cases and are mainly seen in genetic syndromes such as HHT. Most AVMs are diagnosed in the third or fourth decade, presenting mainly with hemorrhage, followed by seizures, and lastly by headache or progressive neurological deficits. AVMs account for only 2% of strokes. However, they are prone to catastrophic hemorrhage by rupture of nidal vessels, rupture of a draining vein, or associated flow aneurysms, or by venous outflow obstruction. Consequently, mortality rates associated with AVM hemorrhage are approximately 6 to 29%. In children and young adults, AVMs are the most common cause of spontaneous intracranial hemorrhage. Approximately 3 to 20% of AVMs are diagnosed in children. Children also have an increased prevalence of flow-related aneurysms. And large AVMs may produce an arterial steal phenomenon, which causes progressive neurological deterioration and potential chronic epilepsy in older children. If AVMs are present in neonates or infants, they may present with congestive cardiac failure, particularly if there is sufficient AV shunting from a large malformation. This slide, also from our chapter, demonstrates the apoplectic hemorrhage associated with a ruptured AVM. A CT scan of the brain of a 26-year-old woman who presented in coma with an acute right occipital intracerebral hemorrhage with intraventricular and subdural extension. CT angiography demonstrates the nidus of the AV malformation supplied by branches of the right posterior cerebral artery and draining into a large varix into the straight sinus. This medial trigonal AVM was approached via superior parieto occipital approach. Intraoperative photographs demonstrate the varix and the AVM nidus with histological section of the AVM. The Spetzler-Martin scale classifies AVMs according to size, location in relation to functionally eloquent cortex, and type of venous drainage. The revised Spetzler-Pons scale stratifies intracranial aneurysms into classes A, B, or C, which correspond to various treatment paradigms. Other classification systems exist, including a supplementary grading system, a modified radiosurgery system score, and the Virginia Radiosurgery AVM scale. Not all ruptured AVMs require surgery. This slide also from our chapter demonstrates a ruptured AVM, which was successfully treated with elective gamma knife stereotactic radiosurgery. Figure A is a CT scan of a 50-year-old woman who presented with sudden onset of headache and visual disturbance, whose scan showed hemorrhage within the right temporal lobe and thrombosis within a varix. In Figure B, an MRA is suggestive of underlying AVM. Subsequent diagnostic cerebral angiography in C and D confirms a choroidal type AVM with a predominant supply from the anterior choroidal artery and secondary supply from the anterior temporal and posterior communicating perforators with drainage via a large varix into the internal cerebral vein. Figures E and F demonstrate stereotactic T2 and T1 images obtained for gamma knife radiosurgery. Figure G demonstrates day of radiosurgery shot planning, where the AVM received a marginal dose of 25 gray. A subsequent magnetic resonance angiogram at 3 years post-radiosurgery was suggestive of obliteration. Subsequent diagnostic cerebral angiography at 4 years following radiosurgery confirmed AVM obliteration without residual shunt or varix. A summary now on other cerebrovascular malformations and their association with brain AVMs. Mixed lesions that include a component of a true AVM are relatively uncommon. Brain AV malformations and an association with capillary telangiectasia is extremely rare, with only one case being published in English-speaking literature. Brain AVMs and venous anomalies are known to exist, but they are generally considered a rare occurrence. More common is the association between arteriovenous malformations and cavernous malformations. However, the AVM component of these mixed lesions is often occult and is not diagnosed preoperatively, but rather on the postoperative histology. Venous angiomas, also known as developmental venous anomalies, are congenital venous anomalies. They are the most common intracranial vascular malformation, and there is no evidence that there is any familial inheritance. What is important to note about developmental venous anomalies is that they drain normal brain parenchyma and should not be removed surgically or treated by radiation. A rare association of brain AVM with a developmental venous anomaly is seen in this slide. A CT scan of the brain of a 50-year-old man with an acute intraventricular and pontine hemorrhage. In Figure B, we see digital subtraction angiography, which shows a posterior fossa AV malformation supplied by the left posterior inferior cerebellar artery and the superior cerebellar vermian branches, with rapid AV shunting into the torcula and left transverse sinus. In Figure C, we see an associated developmental venous anomaly on lateral projection, and in Figure D on anterior-posterior projections, and this is best seen in the late venous phase. Capillary telangiectasia, also known as capillary malformations, were described by Blackwood in 1941. They are composed of dilated capillaries with normal intervening neural tissue. They are the second most common intracranial vascular malformation after venous angiomas, with a prevalence of 0.3% in autopsy studies. They generally tend to be clinically silent. However, they have been implicated as being epileptogenic, and a rare variant known as hemangioma calcificans may present with epilepsy and a large mass on the convexity. Cavernous malformations, also known as cavernomas, cavernous angiomas, cavernous hemangiomas, amongst other names, are well-circumscribed, multilobulated, angiographically occult vascular malformations. Though they are associated occasionally with brain AVMs, they are most commonly seen in association with the developmental venous anomaly, which is seen here in this image from our chapter, which shows an axial T2 weighted and a contrast enhanced T1 weighted MRI image of a 25-year-old with a sudden onset of headache, diplopia and dizziness with recent hemorrhage into a pontine cavernoma. The central hemorrhagic products are surrounded by a partial hemosideral ring, which is characteristic, and an associated developmental venous anomaly is also noted, indicated by the arrow. AVMs are considered to be congenital developmental anomalies of blood vessels arising during the development of the embryonic cerebral circulation, and they result from a persistent direct connection between the arterial and venous portions of the primitive vascular plexus in the embryo before the 4th week of gestation. Although most AVMs are considered sporadic, there is increasing evidence that they occur as a result of upregulation or downregulation of multi-homeobox genes which are involved in angiogenesis, such as HOXD320 and HOXB3. There are 3 general categories of AVMs that are recognized as having a genetic component. They are hereditary syndromes featuring cerebral AVMs such as HHT, familial cerebral AVMs without a known genetic cause, and congenital syndromes featuring an AV malformation, for example as part of a developmental neurocutaneous disorder such as Wyburn-Mason syndrome. Genetic disorders, in particular HHT and Sturge-Weber syndrome, have provided significant insights regarding the signaling pathways that govern the pathogenesis of AVMs. Hereditary hemorrhagic telangiectasia, also known as Osler-Weber-Rendow syndrome, is a rare autosomal dominant vascular dysplasia, producing vascular malformations in multiple organ systems, most typically the pulmonary, cerebral, gastrointestinal, and hepatic vascular beds. It is a genetically and clinically heterogeneous disorder. It is diagnosed by fulfilling 3 out of 4 of the Kurakow criteria. Symptomatic brain AVMs are present in up to 5% of patients with HHT. Up to 13% have been reported in screening for asymptomatic lesions. In general, HHT brain AVMs are smaller, have lower Spetzler-Martin grade, have less temporal lobe involvement, are multiple, and have a lower hemorrhagic risk when compared to their sporadic counterparts. HHT1, where the primary genetic effect is that of a deficiency in endologen, it has a much higher incidence of pulmonary and brain AVMs. HHT2 is a much milder disease. Though the primary defect in HHT1 is endologen production, analysis of its expression in sporadic AVMs has revealed no reduction or mutant forms. This suggests that endologen deficiency may not be directly involved in the generation of sporadic AVMs. This slide provides a summary of the subtypes of HHT and the responsible genetic mutations. Knockout mice lacking endologen or ALK1 die during gestation secondary to defective vascular development, thus suggesting that both are critical for normal vascular development. It is postulated that haploinsufficiency is the predominant genetic mechanism in HHT, where the inheritance of a mutation leading to reduced levels of the proteins on the surface of the vascular endothelium and hence predisposing affected individuals to development of HHT-associated vascular lesions. The precise mechanism by which endologen and ALK1 mutations result in vascular abnormalities is unknown, but both proteins play a role in the TGF-beta signaling pathway, and consequently they affect downstream SMAD proteins, which enter the nucleus and regulate gene transcription involved in angiogenesis. Familial brain AVMs, in the absence of an angiodysplastic syndrome such as HHT, are exceedingly rare. Some have proposed an autosomal dominant mode of transmission with variable penetrance, or an X-linked recessive pattern of inheritance, but at present the mechanisms remain unknown. In general, familial brain AVMs tend to have younger presentation with multiple brain AVMs. There are congenital syndromes that are associated or have as their feature brain AVMs. Their etiology is unknown, but is suggestive of an underlying defect early in vascular development. There are rare syndromes that feature brain AVMs in conjunction with a cutaneous vascular malformation. An example of this is Wyburn-Mason syndrome, also known as unilateral retinocephalic vascular malformation, which consists of cutaneous vascular nevi, retinal and optic vascular malformations, and ipsilateral or bilateral brain AVMs. This next slide from our chapter shows a CT scan of the brain of an 8-year-old boy who presented with sudden onset of left hemiplegia. His CT scan showed hemorrhage within the right thalamus and posterior limb of the internal capsule. A subsequent T2 MRI scan showed multiple small vascular flow voids within the thalamus and basal ganglia, suggestive of an underlying AVM. CT angiography demonstrates the nidus of the AVM supplied by branches of the right anterior cerebral artery, and this is confirmed by digital subtraction angiography. Figure E shows fundoscopy, and here we see multiple dilated and tortuous retinal vessels. These findings together confirm the diagnosis of Wyburn-Mason syndrome, also known in the French-speaking world as Bonnet-Deschamps-Blanc syndrome. Patients with extensive retinal AVMs are at high risk for visual loss with this disease, whereas patients with brain AVMs are at risk of parenchymal hemorrhage and its consequences. The name of the syndrome refers to Roger Wyburn-Mason, who is a neurologist at the National Hospital of Neurology and Neurosurgery. Advances in our understanding of angiogenesis and vascular remodeling have provided new insights into the pathophysiology of brain AV malformations, and as a result, potential new treatment strategies are emerging. Acting as AV shunts, brain AVMs exert significant effects on the cerebral hemodynamics. Generally, in the presence of an AV shunt, there is venous hypertension downstream and arterial hypotension upstream. There is ongoing vascular modeling and angiogenesis, which is presumably triggered by the local aberrant hemodynamics. The rapid shunt flow results in an increased total volume of blood flow through the AV shunts, which in turn results in cerebral arterial hypotension along the path of the shunt. In fact, patients with AVMs have a progressive decrease in arterial pressure, which proceeds from the circle of Willis to the AVM nidus. In patients with large high-flow AV shunts, there may be normal brain regions in which the cerebral arterial hypotension is below the range of normal autoregulation.
Despite this significant cerebral arterial hypertension, most patients appear asymptomatic and free from any ischemic symptoms. These hypertensive normal brain regions can be demonstrated, for the most part, to have relatively normal levels of tissue perfusion, which implies that there is some adaptive change in the face of total cerebrovascular resistance. The variable nature of the clinical course of AVMs, especially with respect to their propensity to growth, regression, and spontaneously hemorrhage, suggests that there are active vascular changes taking place. The endothelial cell turnover rate in AVMs appears to be somewhat between that of normal endothelial cells and endothelial cells in progressive tumors. There appears to be a series of angiogenic factors acting in concert to maintain the AVM phenotype. The most prominent of these are vascular endothelial growth factor, angiopoietin, and TIE2, and the matrix metalloproteinases. Vascular endothelial cell growth factor, also known as VEGF, is a potent endothelial cell mitogen which represents a crucial family of signaling molecules that regulate angiogenesis. It is overexpressed in response to hypoxia-induced factors within the AVM nidus and adjacent astroglia, and is believed to contribute to AVM formation. The differential expression of angiopoietins has been associated with AVM vessel stability, and the interaction between angiopoietins and VEGF may have a role in AVM development. Angiopoietins and the receptor TIE2 play a critical role in angiogenesis and vascular stability. Angiopoietin 1 is an agonist for the TIE2 receptor and promotes the interaction between endothelial cells and the periendothelial support cells to stabilize blood vessels. Angiopoietin 2 is an antagonist for the TIE2 receptor that acts to destabilize these attachments by preventing stimulation of TIE2 by Ang1. The angiopoietin 1 TIE2 circuit allows or mediates vessel maturation from simple extracellular tubes into complete vascular structures, i.e. a construction phase. When expression of angiopoietin 2 blocks the angiopoietin 1 signal, vascular deconstruction ensues. Dysregulation of the feedback system in the angiopoietin TIE2 system may be associated with the pathological angiogenesis observed in AVMs. Matrix metalloproteinases are a family of proteolytic enzymes that degrade the extracellular matrix proteins, cell surface molecules, and pericellular substances. MMPs create a microenvironment that facilitates angiogenesis and vascular remodeling. One of the names for MMP is gelatinase B, and it was originally used for injection into the brain as one of the models for mimicking intracranial hemorrhage. High levels of MMP have been associated with blood vessel rupture, and also they have been noted in brain AVMs. Consequently, there is an increasing interest in using MMP inhibitors in treating vascular diseases, including abdominal aortic aneurysms. It has been proposed that pharmacological inhibition of MMPs may stabilize the unstable blood vessels and prevent complications such as vessel rupture. Tetracyclines such as minocycline and doxycycline have shown significant reduction of both plasma and tissue MMP9 in patients with abdominal aortic aneurysm. Clinical trials were also conducted to assess the feasibility of tetracycline as a potential vascular static therapy for AVMs. Angiogenesis and vascular remodeling are controlled by the orchestration of a number of key angiogenesis-related factors. They may be responsible for maintaining the angiogenic phenotype of AVMs and thereby determining the clinical course. MMP9 appears to initiate and sustain angiogenesis by increasing the bioavailability of VEGF. Angiopoietin 2 in turn appears to increase MMP9 expression in the presence of VEGF. The intricate balance between these angiogenic factors may be what determines the angiogenic potential of AVM. Inflammation and extracellular matrix remodeling have also been implicated in AVM growth and rupture. Recent studies using gene microarray techniques have been able to study multiple pathways simultaneously in AVM specimens and have shown that microRNA 18A normalizes dysfunctional endothelial cells from cerebral AVMs by decreasing VEGF secretion and increasing expression of thrombospondin 1, which is a physiological antagonist of VEGF. Future studies are expected to lead to new candidate genes or proteins to be analyzed in AVMs. Despite the recent progress in identifying abnormal expression profiles of various angiogenesis-related factors in AVMs, the events that lead to AVM development and formation are not well understood. Using careful observation together with clinical collaboration in large sample volumes can provide important insight data into the pathophysiology of AVMs, especially when this is combined with findings from experimental angiogenesis models. This has allowed some researchers to demonstrate new hypotheses. This figure here illustrates the response to injury model as proposed by Young and co-workers from UCSF. Essentially, in the presence of certain genetic backgrounds, this otherwise normal injury repair process can lead to a vascular dysplastic response, indicated by the red arrow, especially when signaling through aberrant ALK1 or ENG pathways or any other closely related pathway, as highlighted. Other contributory pathways include physical forces such as endothelial shear stress from the high flow rates, also inflammation and involvement of circulating precursor cells, which can affect this response. The authors also proposed a second model known as the circular model, which suggests a circular or reverberating pathogenesis for vascular malformations. After an inciting event, normal vessels stabilize, but an incipient AVM undergoes a dysplastic response. The AV shunting and high flow rates synergize with the dysplastic response and inflammatory signals, producing a vicious cycle in the area around the nidus. Development of a vascular malformation might become self-sustaining through the opening of new AV shunts and increased flow. The high flow increases endothelial shear and activates nitric oxide synthetase and nitric oxide production, further driving VEGF stimulation. Further downstream, the activation of MMPs ultimately destabilizes the vascular walls and sets the stage for rupture. Investigations into the pathobiology of AVMs have resulted in a number of potential druggable targets for brain AVMs. This recent published paper would have been considered a work of science fiction only a decade ago. Perhaps the most exciting development since the publication of our last chapter has been the discovery that somatic activating mutations in the CRAS gene have been identified as a cause of AVM. Researchers performed whole exome sequencing on resected brain AVM tissues and found mutations of the CRAS gene in over 60% of all sporadic brain AVMs. In addition, MEK-ERK pathway activity was found in all the AVM tissues examined, even those without detectable mutations of CRAS. This finding indicates that excessive activity of this pathway is a central feature in the pathogenesis of AVMs. Increased mutant CRAS activity can potentially affect a multitude of downstream cell signaling pathways such as RAF-MEK MAP-ERK, P13K, and AKT-mTOR. Subsequent studies have identified KRAS mutations which specifically activate the MAPK-ERK pathway in brain endothelial cells, and in addition, researchers were able to inhibit this using a MEK inhibitor. Subsequently, researchers have reported a high prevalence of KRAS-BRAF mutations in up to 87.1% in AVMs using the more advanced technique of next-generation sequencing, and have advocated the development of therapies to specifically inhibit this pathway. Furthermore, a paper from last year studied KRAS function in zebrafish and mice models. They found that endothelial cells, which were transfected with mutant KRAS, have increased cell size and sprouting behavior. They develop tortuous vessels with dilated lumens, and abnormal connections were found to have occurred between arteries and veins, i.e. de novo arteriovenous malformation. Most importantly, these endothelial cells do not show increased proliferation as in cancer. Furthermore, the researchers were able to inhibit the MEK-ERK signaling pathway, which is related to angiogenesis, but not the P13 pathway, which is related to carcinogenesis. And they were able to suppress the KRAS-induced gene signature in cultured endothelial cells, and were in fact able to reverse arteriovenous malformation and shunts in the zebrafish model, but not as yet in the mice. This opens up a potential whole new pathway for perhaps inducing regression of established arteriovenous malformations. In summary, brain vascular malformations are classified according to their histological features. True brain AVMs are composed of feeding arteries, draining veins, and a dysplastic vascular nidus. Classically, brain AVMs are considered as congenital lesions. However, there is increasing evidence that indicates that they occur as the result of upregulation or downregulation of multiple homeobox genes, which are involved in angiogenesis. AVMs are dynamic lesions, and increasingly are recognized that they may enlarge, regress, obliterate, and even recur. Brain AVMs are predominantly sporadic, but can occur in certain hereditary diseases, such as hereditary hemorrhagic telangiectasia. Mouse models of angiogenesis, combined with studies of human AVM tissue, have been used to investigate the pathogenesis of AVMs. Advances in genetic sequencing now permit the simultaneous study of multiple pathways in AVM specimens. Whole exon sequencing has confirmed the significant role of the BMP, TGF-beta, and VGFR signaling in the pathogenesis of AVMs. More recently, somatic activating mutations in the KRAS gene have been identified as a cause of AVM. Given the high prevalence of these mutations in AVMs, novel agents that specifically inhibit the RAS-RAF pathway could potentially be developed to treat or modify the clinical course of brain AVMs. In conclusion, the research findings from observational and experimental studies have revealed the abnormal expression profile of angiogenesis-related factors in AVMs. Despite advances, invasive treatments for brain AVMs are not without risk and now have to be rebalanced in light of recent natural history studies such as Aruba. In the future, treatment modalities will favor advanced, minimally invasive strategies and perhaps pharmacological approaches. Furthermore, potential new therapeutic targets to control angiogenesis
and therefore modify the clinical course of AVMs are emerging. Thank you for listening.